Thanks, Larry. I have to give credit to my brother, actually, for the talk title. He's a lawyer and a bit of a Renaissance man, and I was talking about needing something more exciting than retroperitoneal sarcomas, and after I showed him a few pictures, he came up with the title talk. So I'm not normally that creative. For my disclosure, I have nothing to disclose. There's no money in this work. Nobody sponsors you for anything, and there's no drugs that work either. So I had a few people actually ask me why I was giving rounds to the urologists. So this is my slide explaining the rationale for these rounds. So this is just, stolen from Google Images, which is where we all get our pictures. And these are three, I kid you not, pictures of one of renal cell carcinoma, one of an adrenal cortical carcinoma, and one of a retroperitoneal sarcoma. And other than the fact that the adrenal cortical happens to be on the left side, because I couldn't find a picture of one on the right side, to my mind, these three conditions don't look any different. Yet, most of you spend your time dealing with renal cell carcinoma and adrenal cortical carcinoma and don't see many retroperitoneal sarcomas. And so your approach to these tumors tends to be directed to your understanding of the behavior and surgical approach to renal cell and adrenal cortical carcinoma. And most of the time that's fine, and some of the time that's not fine. So just to give you a little local perspective, recently one of my residents undertook a provincial review, and we looked at the 2000 to 2009 BC Cancer Agency Cancer Information System database, and she looked up all patients coded with retroperitoneal tumors in that decade, and we identified 228 patients, and after sifting through all of the things that weren't retroperitoneal sarcomas, there were identified 86 cases of retroperitoneal sarcoma for which we had outcome data available. That means that the patients were actually at some point referred to the cancer agency, so we have all of their information. Of those, 14 of those patients were operated on by urologists, and only 2 of those patients were seen at the cancer agency prior to their surgical intervention. And you'll see as I go through the talk what the relevance of that was. And when she read through the pre-operative consults, half of those 14 patients, the preoperative diagnosis was thought to be a renal cell cancer. So the first case I would like to present is a 46-year-old woman who presented with a palpable mass in her abdomen. She had an ultrasound done which described a 15-centimeter mass, and proceeded then to have a CT scan of the abdomen which showed this lesion, which, other than being a different cut than the previous ones that I showed you, shows a similar large retroperitoneal mass in a suprarenal location. And I find when you read radiologist reports, the options of the diagnosis depend a lot on the experience of the radiologist. And some of them will say it's an adrenal cortical carcinoma because it's a suprarenal mass, and others will give you a very long differential. And unfortunately, some of us rely on the radiologist's interpretation of what this likely is. So she was seen by a community urologist and had an appropriate metabolic workup to rule out a pheochromocytoma. And the clinical preamble in the operative note says that she was taken to the operating room for an adrenal carcinoma invading the kidney and the vena cava. And at the time of the surgery, this was described as a 25-centimeter tumor. The pathology showed a high-grade leiomyosarcoma, which was 18 centimeters in maximal dimension. The margins were involved. And while the operative note describes a complete removal of this tumor, the pathology report has these two statements in it, which I've taken as a quote. It was a multinodular mass with a torn outer surface and exposed tumor, and some of the tumor was present as separate fragments. So she was referred, as is often the case, to the cancer agency following her surgery for a conference review and opinion regarding adjuvant therapy for her sarcoma. And unfortunately, the operative field following the surgery was felt to be too big for adjuvant radiation therapy. There was no role for adjuvant chemotherapy in these tumors, and she is identified as extremely high risk for recurrence. And she is currently on follow-up. And this is just 6 months post her surgery, so I can't tell you what's going to happen with her, but though I know what's going to happen with her. But just to give a very similar example of what's going to happen, this is almost the identical case. A patient operated in 2006. In fact, also a young woman, about 45 years old, with the same preoperative diagnosis, thought to be an adrenal cortical carcinoma. And her initial pathology was a grade 2 leiomyosarcoma involving the IVC with close positive margins. She had a marginal resection of the IVC, and again, not amenable to postoperative adjuvant therapy, and followed with CT imaging. And 3 years later, so in 2009, she recurred with a 2.3 centimeter mass on the IVC, and there was no evidence of distant metastases. And this is just to show you what her CT scan looked like when she recurred. And you can see this small mass right here, abutting her IVC and the gallbladder. And she was again discussed at conference. And since we had a localized target to address, she did receive 5 weeks of radiation therapy. And then she was taken back to the OR by a combined team of urology, vascular surgery, and myself, and had an en-bloc resection of her gallbladder, most of the sidewall of her IVC, as well as a renal artery. She had sort of 2 renal arteries to the kidney on that side. On the final pathology, it was a 2.4 centimeter mass. The margin was still close on the IVC. We had taken it all the way up to the intrahepatic cava and couldn't go any farther without doing a right hepatic lobectomy, which we decided not to do. And she's now 2 years out without recurrence, but still at high risk. So these are 2 randomly pulled cases, actually, of ones that were just presented at Sarcoma Conference when I was there, so they're our local experience. Obviously, the retroperitoneal sarcomas are uncommon tumors. I mean, overall, only 2% of cancers are sarcomas, and retroperitoneal sarcomas represent only 10% of all of the sarcomas. They're most common in the 5th decade with an equal male to female ratio. And when you look at retroperitoneal masses in general, so this is important for your perspective, a third of them are actually sarcomas. And in general, the majority of retroperitoneal soft tissue tumors are malignant. So occasionally we'll see very fatty tumors that a less experienced radiologist will say this looks like a lipoma. And though I've operated on one in 15 years that looks like it was a lipoma, basically they're never lipomas. And really, obviously, for the renal cell cancers and adrenal cortical tumors and sarcomas, the best treatment, surgical and adjuvant, is a function of what the tumor actually is. There's a wide differential diagnosis for the retroperitoneal tumors. I do get referred a lot of retroperitoneal masses, and sometimes you can look at the imaging and say this is unlikely to be a sarcoma. If we see tumors that are abutting the spine or abutting the sacrum, they're often of neural origin and are schwannomas. If there's a lot of elevation of the IVC with the mass or the aorta, it's often a lymphoma. And of course, even very rarely I actually have something sent to me that turns out to be renal or adrenal, though that doesn't happen very often. And occasionally metastatic, delayed metastases for metastatic nodes from testicular tumors. If we look overall in the retroperitoneum, the majority of tumors are liposarcomas, and what makes the diagnosis difficult for the radiologist is they don't always have a substantial fatty component. You can have a large amount of dedifferentiation, both high-grade and low-grade dedifferentiation, that can make the mass look quite dense. And sometimes there's only a small amount of fat at the rim that you have to sort of appreciate that there's some asymmetry there to realize that this is a liposarcoma. When I looked at the number of the cases done by urology in the community, the more common diagnosis has actually been leiomyosarcoma because they're tumors that have originated off the IVC or off the renal hilar vessels in that suprarenal renal location. And the third is malignant fibrous histiocytosarcoma. The tumor staging, just because you can't talk about cancer without talk about staging, we do use the TNM classification, but really in a very general way. The grading is an important aspect of the staging of the tumor with the usual grade 1 to grade 3. Basically, any tumor that's greater than 5 centimeters is already a T2, and tumors are classified as being superficial or deep. So every retroperitoneal sarcoma is a deep tumor, whereas if you look at extremity or truncal lesions, you can have lesions that are superficial to the fascia, and that's not a deep tumor. So all retroperitoneal and pelvic tumors are classified as deep. And then when we look at the staging, if you have anything that's intermediate to high grade or bigger than 5 centimeters, you're looking at stage 2 or 3 tumors. And basically nearly all retroperitoneal sarcomas are large and greater than 5 centimeters and deep to the superficial fascia when you find them. So it's an exception to see a low-risk tumor. So nearly all are stage 2B or stage 3, and really the difference is whether it's high grade or low grade on pathology. Most of the patients have a massive tumor at diagnosis unless it happens to be incidentally picked up on imaging, found for something else. And unfortunately, or fortunately, a lot of people have abdominal ultrasounds for abdominal pain, but surprisingly, these masses are often not appreciated. There's a lot of focus on the ultrasound on looking at organs specifically, and sometimes you can miss the forest for the trees and miss a large retroperitoneal mass on ultrasound. You can have quite vague abdominal pain, abdominal protrusion, and vague intestinal complaints, and it always amazes me how much abdominal bulk and distension people will tolerate thinking it's natural middle-age spread, including like 50 centimeters of liposarcoma in their abdomens. Most people have at least 4 months of symptoms before they're diagnosed. And occasionally, and it's a clue to a retroperitoneal mass, a patient can present with some vague abdominal pain with discomfort in the anterior thighs because of involvement of the genitofemoral nerve or invasion of the psoas. So I've seen it only a couple of times, but it's a clue that there's something going on in the retroperitoneum. And occasionally, we do see the unexpected finding at laparotomies done for other diseases, particularly in gynecology, where the patients often do not have CT imaging before they're operated on for adnexal masses because the CT doesn't change the operation for an ovarian cancer, so they often rely on ultrasound imaging and don't appreciate that the tumor may be actually involving the retroperitoneum or the pelvis. The approach to retroperitoneal sarcomas is quite different than the approach in general to renal cell cancer in that we do rely on core biopsy for tissue diagnosis. And basically, if we see something in the suprarenal location, we will do a functional investigation to rule out a pheochromocytoma. But then we do a core biopsy. And we biopsy these from a retroperitoneal approach to avoid peritoneal contamination with the tumor. And though traditionally with extremity sarcoma, the biopsy is planned and the biopsy tract marked so that it can be included with the excision, we obviously don't excise the biopsy tract done through the retroperitoneum because it's really not technically doable. And because of this and the lack of experience generally in the community with community radiologists in biopsying retroperitoneal tumors, it is beneficial to get an early referral for consultation for these patients and have the biopsies done in places, fortunately like here, that have a good experience with the approach to these tumors. Once we have a diagnosis of sarcoma, we do CT scan of the chest, which is the most common site of metastatic disease. Unlike an extremity sarcoma where we do MRIs for local staging, usually a CT abdomen and pelvis is adequate for imaging the retroperitoneum. Occasionally an abdominal MRI if there's some question about involvement of the aorta or IVC, like true involvement as opposed to abutting the tumor. We've done some investigations on low-grade liposarcomas as to whether PET scans are helpful to identify high-grade dedifferentiation that's not appreciated on the imaging, and it's not helpful. And for an older patient where a nephrectomy is going to be part of the treatment, we'll do a differential renal scan to ensure that there's going to be adequacy of renal function on the other side. Not that it's necessarily meant that we haven't done the nephrectomy, but it gives us a heads up, and getting nephrology involved early and being able to warn the patient that they're going to have some chronic renal dysfunction after the surgery. From a surgical perspective, the things that are important is that the main determinants of the prognosis and survival are the tumor grade, which you can't change, and the resectability, which you can change. And patients who have a successful complete resection and also have low-grade tumors have the best survival rates. Again, looking at the BC data from the last decade, as I mentioned, there were 86 patients that we had outcome data available. 43 of these patients, by chance, were referred to the cancer agency or to see one of us in the general surgical oncology group prior to their resection, and 43 were referred after their resection. And if we just look grossly at the outcome data, 42 out of the 43 who were referred before resection had a complete resection, as opposed to 27 out of 43 who were referred after. And on follow-up, 34 out of the 43 who were referred before resection were still alive, as opposed to 18 out of the 43 who were referred after, and that was statistically significant for both. And hopefully, but my resident is working on a survival analysis curve in more detail, because this is just a project that's currently underway. So when I talk to our residents and to the community general surgeons, what I say to them is that a large mass is not an indication for an emergency operation. And a lot of the surgery that's done for these in the community is done on an urgent basis. Patient comes in, they have a CT scan because they have vague abdominal pain. There's a huge mass. They're booked for the OR in a week. And the patients that I see before their surgery often have an expectation that their surgery is going to be within a week because they have this enormous mass, which has clearly been there for a long time. Otherwise, they would have had acute abdominal pain if it grew quickly. And I do spend a lot of time having to calm everybody down about the fact that we need to do this right as opposed to do it fast. And the pressures of the family and the referring doctor and the radiologist and their neighbors and everybody else is not an indication for an emergency operation. I teach our residents to ask yourself, is there any contraindication to a tissue diagnosis beforehand? And what are the cons of doing that, and being a lot more thoughtful in the approach to getting into the operating room and all of the unexpected things that might happen if you haven't given this some good thought beforehand. For those of you who don't have the liberties of working in a center where there's a vascular surgeon and a general surgeon and everybody else involved to help, you have to appreciate that when you're doing with a retroperitoneal sarcoma, 75% of complete resections require the resection of at least one adjacent organ. And from my perspective, it's not bad because it's usually the kidney or the adrenal, but for the community urologist, it may be a little unexpected because it may be the bowel and something that you're not used to dealing with yourself. So you do need to be prepared. Even though on the imaging it looks like these are just pushing tumors and they just look like they're abutting organs, they actually do tend to invade the contiguous organs. And even if it's not apparent on imaging, the resection of the contiguous organs is necessary to get a clear margin. The sarcomas have what's called a malignant pseudocapsule. It gives the impression that you can just shell out the tumor, so it looks like you're getting a nice edge. But in fact, that pseudocapsule is malignant, and resection at that level is associated with about an 80% local recurrence rate. And I'm sorry it's blurry, but this image is of a sarcoma pseudocapsule. So this is the capsule that's come off in the specimen. This is actually a small blue cell tumor, which is a different kind of sarcoma, but you can see all the blue cells in the tumor, and you can also see all of the blue cells in the capsule. Right, so this is not a standard fibrous capsule, it's compressed malignant cells. If you look at the literature overall, the complete resection rate runs between about 65 and 99%, with the highest quoted complete resection rates being in centers with very high volume practices. So our stuff published from Memorial Sloan Kettering, MD Anderson. And definitely the complete resection has been shown to improve the survival. More importantly, incomplete resection is completely ineffective and has no survival benefit except for extremely low-grade liposarcomas. And the other important thing is that you're much more likely to achieve a complete resection on the first operation. So though there have been reports of successful complete re-resections en bloc from tumors that were shelled out in the first place, the local recurrence and survival is not as good as if you get it right the first time. As far as the unexpected retroperitoneal mass, which perhaps doesn't apply to your group so much unless you're called into the operating room by your general surgeon in the community who's found something unexpectedly in the retroperitoneum, we don't actually recommend an incisional biopsy because we don't know what it is. The incisional biopsy has been shown to contaminate the peritoneal cavity and decreases the cure rate. And if you can do a core biopsy intraoperatively with complete hemostasis and without puncturing a cystic component with the tumor, that's acceptable, but we shouldn't mobilize colon off the mass because what looks like the colonic mesentery may be compressed pseudocapsule. So most of the time I just back out and investigate it as though you had never known it was there to start with. From my perspective, the preoperative multidisciplinary conference should be the goal for all patients with retroperitoneal tumors. In BC, we do give preoperative radiation for high-grade tumors or for low-grade tumors where it's anticipated that a wide excision is not going to be feasible. So, for example, if it looks like a low-grade sarcoma, but it's abutting the iliac vessels, I won't take the vessels for that, but we'll give neoadjuvant radiation. And we can sometimes give radiation for limited local recurrence of a tumor. Unfortunately, radiation hasn't been studied in any randomized controlled trial, and ICOSOG did try to develop a randomized controlled trial of preoperative radiation therapy for retroperitoneal sarcoma just in about the last 3 years, but the accrual rate was really low because there's very set patterns of practice. And for example, if you go to MD Anderson, you get radiation. If you go to Memorial Sloan Kettering, you never get radiation. If you go to the Mayo, you get intraoperative radiation. If you go to Brigham and Women's, you get radioactive seeds, and you absolutely must have that treatment as far as they're concerned. And if you send your patients there, they'll send you a very nice list of references supporting why they do what they do. So, I did my training in Toronto where they gave radiation, and I brought that here, so we give radiation. Most of the patients that are referred post-operatively are referred with the expectation that they're going to be given radiation for their positive margins. But in fact, it can't be done because once you take that big tumor out of the retroperitoneum, all the small bowel falls into that space and gets stuck. So the 4,500 or 5,000 centigrade that needs to be given for effective treatment of a sarcoma can't be given to the fixed small bowel without unacceptable toxicity. Furthermore, the approach from the radiation oncologists is when they're radiating post-operatively, they have to radiate the whole scar, right, as part of the operative field. And generally in that situation, the operative field is too big and they would have to give whole abdominal radiation at a dose that the whole abdomen can't handle. So it's essentially a no-go. We've done it twice in patients who had very laterally based tumors that I was able to take the patient back to the OR and put a spacer in to move the bowel out of the way, and then they gave radiation, but that's like twice in 15 years. And those two actually so far have not recurred, but that's an exception to the rule. So when we look at the evidence for radiation therapy, it's extrapolated from extremity sarcoma, where in extremity sarcoma, preoperative radiation has been shown to decrease the local recurrence rate in high-grade tumors. For retroperitoneal sarcoma, there's one randomized trial using intraoperative radiation therapy, which we don't have here or anywhere in Canada, and it did show improved local control. There are several retrospective and prospective studies that suggest improved local control. There's some evidence, though, that the radiation delays but does not prevent the local recurrence. And this last study with the reference showed it decreased the local recurrence rate and also the time to local recurrence, but there was no change in overall survival. So what about chemotherapy? So we do, in high-grade disease, administration of adriamycin and ifosfamide can yield partial responses of about 50% with some increased overall survival, but complete responses are seen in less than 10% of patients. It's not used as a standard adjuvantly. It's used to treat metastatic disease. We do have a protocol for patients with very large, high-grade, deep tumors that are otherwise very fit. So that basically means they're like 55 or under. Of giving them neoadjuvant chemotherapy, and they get 5 cycles of chemotherapy, and provided their tumor isn't enlarging rapidly on that treatment, they then get their radiation and then go on to surgery. In my own personal practice, I think I've had 3 patients complete all of that treatment. The first 2 were the first ones in this protocol, and they were both 40-year-old women with very ugly tumors, and they were operated on now about 7 years ago without recurrence, which was unbelievable, and those are the 2 best results I have. It's been downhill since then, with most patients not actually making it through their chemotherapy because of progressive disease. So we, like every good study, it works great for the first 2 seconds, and then it doesn't work so great, but we still try it. The most common site of distant metastases in sarcoma is in lung, and unlike for carcinomas, there is a 25% prolonged relapse-free survival with resection of pulmonary metastases in sarcoma. So these patients will be referred to thoracics for consideration of resection. Excuse me. So the sad news that starts to hit you about 5 years into your sarcoma practice is these patients don't do too well, even though you do a really good job. The 5-year survival rates are about 50%, with a broad range in the literature, and about 36% for 10 years. There is good evidence that the higher survival rates are associated with an increased magnitude of resection. So the bigger the operation en bloc, all the adjacent organs, you're looking at almost a 50% survival rate at 10 years. The most frequent site of recurrence is local in the surgical bed, and most of the recurrences occur within 2 years, but if you're dealing with a low-grade liposarcoma, the recurrence can be very delayed, and you can see people with recurrence 10 years after their initial resection. So they need long-term follow-up. Occasionally, patients with local recurrences can be suitable for re-excision, and for those patients that have a resectable recurrence, their median survival is improved with survival of about 60 months following resection versus 20 months without. But it really is not generally curative surgery, and sometimes we'll watch a recurrence for some time until it looks like it's getting to a point where it's going to become more technically difficult to resect or becoming symptomatic before we offer surgery. Again, depends a little bit on whether the patients had full treatment beforehand or whether they had incomplete therapy beforehand. As I said, cures following re-excision of lesions that were not treated with primary wide local excision have been reported, and we're hopeful that the patient that I presented at case number 2, who did not have full treatment up front and then had it on the recurrence, maybe now she's 3 years out with a recurrence, maybe she has been cured. With patients with very low-grade liposarcomas, you can have prolonged palliation, and I'm following patients who had their original surgery in the early 90s before I came to BC, and they're now hitting their 5th resection for recurrent low-grade disease. Now they start to develop high-grade dedifferentiation and become inoperable, but they've lived basically 15 years with recurrent disease in their abdomen. There really is no value for resection of rapidly growing high-grade tumors, though I get pressured a lot to do it. It's no survival difference than non-operative management of these patients. And that's a hard thing as a surgeon to tell people that you're not going to take this thing out. It's hard to tell the medical oncologist that you're not going to take it out either, because they do ask you at least 15 times. I try to, in my dictations on my last time I'm willing to operate on somebody, to dictate that there's no role for further surgery in this patient, so it gets documented then, but that doesn't always stop the phone calls. We follow these patients quite closely. The frequency of imaging follow-up a little dependent on how high grade their tumor was to begin with, but typically, a minimal of about imaging every 6 months for the first 5 years. And then once a year after that, again, depending on whether it was low-grade or high-grade disease. So I've been here since 1998. I question whether we're getting any better. So I thought I'd present our most recent case. And this is a 57-year-old man who His wife actually thought he looked a little funny, a bit asymmetry. He thought he was getting old also, but he did finally see a physician and who noted that he did have a large mass in the left upper quadrant. And he had imaging which showed a 23 centimeter mass, which was the radiologist felt was possibly an adrenal carcinoma, and but did indicate that the differential was a retroperitoneal sarcoma, and he was referred to one of the community urologists who I've had a number of interactions with over the years with regards to sarcoma. He just had a bit of a weird practice early in his career, and but looking at sarcomas of the groin and inguinal canal. And he did think it was adrenal carcinoma, but thought it was going to require a more complex resection. So he referred it into Vancouver General Hospital to one of the group here because of the potential technical challenges of the surgery. And that urologist did a FEO workup, which was negative, and then having had some discussions with me previously, did actually arrange a CT-guided biopsy. And just to show you this fellow's mass. So again, a large mass. It had cystic degeneration. It is located, I'll show you on the next image, in a suprarenal location, right? So kidney down here, you guys know that one, right? But as soon as I saw these images, which was after I actually heard about the biopsy, what I noted on this is this ball of fat. So just looking at this imaging and not reported by the radiologist, this is a retroperitoneal liposarcoma with dedifferentiation because there's this big mass and it has a fatty component at the periphery and then something else going on. And they did a retroperitoneal biopsy and just biopsied this component of the thick wall here. And the core biopsy came back as a liposarcoma with some low-grade dedifferentiation, which really wasn't consistent with that big cystic thing in the middle because low-grade tumors don't do that. But he was then referred to see me. He had a CT scan of his chest, which did not show any metastases, and he was presented at Sarcoma Conference. And we felt that because the imaging showed high-grade features, even though the pathology did not, that we would treat him as a high-grade tumor. And fortunately, a very keen young radiation oncologist felt that even though the field was quite big, it was still amenable to preoperative radiation. And he had his preoperative radiation and was taken to the OR for a planned surgical resection to include, let me just go back here. Don't know where they're included. So there's his spleen up here, right? And not appreciated on the lower images is that his pancreas is sort of sitting on its head with the head down here and the tail pointing up in the air and the kidney plastered over the front of this thing. So for a planned nephrectomy, distal pancreatectomy, and splenectomy. And this is the picture of his tumor. This is the basin that the nurses keep all of their stuff in. So it filled this thing. That's the spleen sitting on top. My resident with the iPhone camera, so a little bit fuzzy, sorry. So this specimen included the left nephrectomy, distal pancreatectomy, and splenectomy. The specimen was 47 by 25 by 15 centimeters, and it is a high-grade dedifferentiated liposarcoma. And much to the astonishment of both myself and the pathologist, the actual margins are clear. As opposed to a gross complete resection, they're actually microscopically clear, which very rarely happens because even though we go all the way into the retroperitoneum and take the fascia off the psoas and the posterior muscles, there's often low-grade liposarcoma in the back of these. So that's our most recent case. He just went home from hospital last week, so I don't know what the outcome is, but I think we gave him the best possible care. And finally, I'd just like to thank Dr. Alan So and Peter Black for inviting me to speak to you, and I'd be happy to take any questions.